Good morning to Dr. Camelia, to all chief residents, to my fellow residents, and to all co-assistants. Thank you for the opportunity this morning. I would like to present a case report on thyroid carcinoma. Let me begin first with introduction. So thyroid cancer is the most common endocrine malignancy. It rarely causes The thyroid cancer rarely causes a glandular enlargement. More often, it causes small growths or nodules in the gland. The diagnosis of papillary thyroid cancer has increased dramatically in recent years, particularly due to increased screening thyroid sonography in asymptomatic patients. However, mortality has remained extremely low in these cases. Overdiagnosis of thyroid cancer has been known in the recent years, and it is defined as diagnosis of thyroid tumors that would not, if left alone, result in symptoms or death, which is 70 to 80% of all thyroid cancers in women and 45% of cases in men. So the incidence itself has increased dramatically from 3.6 per 100,000 populations to 8.7 per 100,000 population, 100,000 people. And in 2012, there's 230,000 new cases per year in United States. However, most of these new cases are asymptomatic, particularly due to the screening thyroid ultrasonography screening. 0.4% of the cases resulted in death. So the mortality rate is pretty low, and the prevalence is more common in female patient than male. Peak incidence of thyroid cancer is in the population 45 to 49 years old patients, especially in female, and 65 to 69-year-old, so older in men. In the United States, 275,000 cases of thyroid nodules are detected annually, but only 1 in 20 thyroid nodules is clinically diagnosed as malignant. In Indonesia, thyroid cancer is the fourth most common cancer. So the embryology, it originates from the evagination of the pharynx epithelium or the endoderm. On the 4th week, the ventral diverticulum identified between the tubercle impar and copula. It then descends caudally within the mesodermal tissue until it reaches the adult pretracheal location. On the 5th week, connection between the thyroid diverticulum and the pharyngeal floor begins to disappear. On the 6th week, there's obliteration and atrophy. If the relationship persists at birth, it becomes an anomaly, a congenital anomaly called thyroglossal duct. So the anatomy of the thyroid gland itself, it consists of 2 lateral lobes, weigh around 15 to 20 grams, with the size of 5 times 2 centimeters, and they are connected with the medial isthmus. Sometimes there's also a pyramidal lobe extending superiorly. So the thyroid attaches to the lateral side of the thyroid cartilage, and the upper border of the isthmus is slightly below the cricoid cartilage, and the lower border of the thyroid is on the tracheal ring 4. But sometimes in some patients there are variation. The lower lobes could extend up to tracheal rings, the 6th tracheal ring. So the thyroid itself is encapsulated by 2 layers of capsule. The outer layer is the false capsule, and the inner layer is the true capsule. The false capsule is actually it's from the deep cervical fascia, and the true capsule is the true capsule that encapsulates the thyroid, that it also enroaches inside the thyroid, so it becomes septae inside the thyroid. For the vascularization, the thyroid receives artery from superior thyroid artery, inferior thyroid artery, hemathyroid artery, and the vein flow is from to the superior thyroid vein, medial thyroid vein, and inferior thyroid veins. For the innervation, the thyroid gland receives sympathetic innervation from the cervical ganglion, parasympathetic innervation from the vagal nerve, which are superior laryngeal nerve and inferior laryngeal nerve. For the lymphatic drainage of the thyroid gland goes to the lymph node above the isthmus or the Delphian nodes, paratracheal nodes in front of the trachea, or go to the lymph jugular chains. Histologically, the thyroid gland consists of two different cells, which is the follicular cells and the parafollicular cells. The follicular cells secretes the thyroid hormones, meanwhile the parafollicular cells secretes calcitonin. So physiologically, the thyroid produces two different thyroid hormone, which is the T4 and T3, which the T3 is more active, and the T4 will be converted to T3, especially in the peripheral area of our body. The thyroid gland itself receives stimulation from the TSH or thyroid stimulating hormone from the anterior pituitary. The anterior pituitary receives stimulation from the TRH, or a hormone that is secreted by the hypothalamus. And the thyroid hormone functions, they control almost all metabolism in our body. It controls cellular metabolic activities, cell replication, normal growth, metabolic rate, and etc. So goiter is actually a phrase that describes the abnormalities in size and shape of the thyroid gland. It is usually considered enlarged when the thyroid gland is more than 2 times its normal size. And it is clinically divided according to the symptoms that the goiter itself or the thyroid itself cause. So non-toxic means there is asymptomatic goiter, and toxic means the thyroid gland produces symptoms of thyroid toxicosis, for example. So the thyroid enlargement itself could be classified into different classification. First is based on the anatomy itself. It can be classified into diffuse and nodal. So diffuse goiter means the enlargement is diffuse in the thyroid gland itself is enlarged as a whole. Meanwhile, nodal goiter means there's a nodal enlargement of the thyroid glands. Based on the clinical symptoms, it is classified as toxic and non-toxic, which is the symptomatic or asymptomatic. By function as hyperthyroidism, euthyroid means normal, and hypothyroidism means the opposite of hyperthyroid. And based on the histology, could be classified as hyperplasia or inflammation, benign, and malignant neoplasm. So the pathophysiology, some of the goiter is caused by the iodine deficiency, which is the hallmark or the precursor of thyroid hormone. So if there's iodine deficiency, the body will try to make more of the thyroid hormone, which then resulted in enlarged thyroid gland. For the thyroid cancer risk itself, for the epidemiology, it is more common in women to develop DTC and 2 times more common to develop ATC. DTC means the differentiated thyroid carcinoma, and ATC is anaplastic thyroid carcinoma, which we will cover more later. And the median age at diagnosis is about at 51-year-old, which the peak of the age is older in male compared to female. One of the risk factor known for to cause thyroid cancer is ionizing radiation. So thyroid cancer has been known to have increased prevalence in survivors of, for example, Chernobyl incident. So the thyroid cancer, it has prevalence or incidence of 300,000 new nodules per year, and 1 in 20 nodules is carcinoma, and 1 in 200 nodules is considered lethal. So this is a classification of the thyroid cancer. So the thyroid cancer could be classified from the derivation, the cell derivation. So the first is when the cancer is derived from the follicular cells, which is the function unit of the thyroid. It could be classified further into differentiated thyroid carcinoma. Some call it WDTC, or well-differentiated thyroid carcinoma. And it is further classified into papillary thyroid carcinoma, or PTC, follicular thyroid carcinoma, or FTC, and other variants. And the other is anaplastic carcinoma, which is poorly differentiated thyroid carcinoma. And the second classification is when the thyroid cancer is derived from the parafollicular cells, which secretes the calcitonin. It is called the medullary thyroid carcinoma, or MTC. So these are another classification. And for the signs and symptoms itself, the signs and symptoms, it is very related to the hormone that the thyroid gland itself secretes. So if the hormone itself increase, the thyroid hormone increase, it will cause hyperthyroidism. And if it decrease it will cause hypothyroidism. And if it doesn't change the level or the quantity of the thyroid hormone, it becomes euthyroid. This is the local signs and symptoms of the thyroid cancer. First is the anterior neck swelling, which moves with swallowing. Dysphagia or dysphonia, a history of neck radiation, having a family history of thyroid carcinoma, nodules that are solid, hard, and difficult to move, presence of cervical lymphadenopathy, and solid or mixed image on ultrasound. So the diagnosis, usually the gold standard for the imaging is neck ultrasound. And then it can then further examine using fine needle aspiration or CT scan. So for the case report, this is a 53-year-old female that came with hoarseness. So she complained of hoarseness in the past 7 months with episodes of palpitation, profuse sweating, weight loss rapidly in the past 6 months. She also complained swelling on the anterior part of the neck, gradually getting bigger in the past 3 months. She also complained of dyspnea. She denied dyspnea, dysphagia, and painful swelling. She also denied ear and nose complaint. History of hypertension, diabetes mellitus, allergy, and other systemic conditions were denied. So from the physical examination, the vital signs were within normal limits. And this is the ENT examinations. The ears were within normal limits. The noses were also within normal limits. So the oral cavity and the oropharynx were also within normal limits. However, during direct laryngoscopy, we could find there is a parese on the focal cord, on the right focal cord. On the neck examination, we could find anterior that moved with swallowing. This is the clinical pictures of the patient. And this is the cervical CT scan of the patient. There is a mass on the anterior part of the neck, on the thyroid glands. Here is the more enlarged version. There's also calcifications inside the. So she was then went through USG guided fine needle aspiration cytology, and it was found there is a Bethesda system reporting, which is class 4, which is follicular neoplasm. It has, at this point, it hadn't been known whether this is a malignancy or benign. This is the thyroid panel examination. She had normal THAs, TSH, and also normal FT3 and normal FT4. So she was euthyroid. However, when she was examined on thorax X-ray for the preparation for the surgery, we found suspicious of pulmonary metastasis. Diagnosed with thyroid carcinoma with follicular neoplasm, Bethesda class 4, stage 4B, and she went through total thyroidectomy. So the thyroid that was excised was then biopsied, and it was found out that she had right thyroid papillary carcinoma follicular variant, and on the left thyroid is follicular adenoma with nodular hyperplasia. So the problem that I would like to discuss in this patient is the diagnosis. So for the history taking, the patient has a history of lump in the front of the neck since 6 months ago, and the complaint was getting bigger and was followed by appearance of another lump in the left of neck. She also complained of hoarseness, and this is according to the theory which is thyroid malignancy usually cause. And from the physical examination, there's a right adduction pares of the vocal cord, and there's also mass that moves when swallowing. And from the supporting examination, there is a uterine thyroid panel, and from the US of fine needle aspiracy cytology, there is a follicular class 4, so the follicular neoplasm. And on CT scan, there was a mass in the right thyroid gland that encompasses the trachea. And from the CT scan, it is suggested that the mass is benign. So, from the theory, fine needle aspiration with the guided ultrasound could enhance the visualization of needle placement in the target nodule. And ultrasound, along with fine needle aspiration, is the gold standard for diagnosing thyroid cancer. CT scan is usually secondary and can be used to assess the spread of thyroid carcinoma. So the management, this patient underwent a total thyroidectomy. And from the total thyroidectomy, it was found that she indeed had a thyroid carcinoma of the papillary carcinoma follicular variant. So the thyroid carcinoma grading itself. So it is according to the AJCC 8th edition that was published on 2017. She was diagnosed with this differentiated thyroid carcinoma. So the staging system is differentiated between the DTC and the anaplastic and the medullary thyroid carcinoma. So we used the DTC1, and she was diagnosed with stage 4B. So this is one of the algorithm of diagnosing thyroid nodules. First, we need to perform neck or thyroid sonography, and we classified the findings based on the TIRADS classification, and then we perform FNA or fine needle aspiration cytology based on the TIRADS classification, and then it is further classified based on the Bethesda classification. So the diagnosis of the thyroid nodules, we can suspect of malignancy if we found nodules more than 4 centimeters in diameter, lateral cervical lymphadenopathy, focal cord immobility, and fixation of nodules in surrounding structures. Thank you. Is there any